Welcome, curious minds, to the deep dive. You know, every new parent understands the absolute urgency and tenderness of those first few hours and days with a newborn.
Hmm.
But what about when that baby is tiny, incredibly fragile, a small, sick, or preterm infant?
Yeah,
For these vulnerable little ones, those foundational moments are not just critical, they're truly life-shaping, laying the groundwork for their entire future. Today, we're diving deep into how health facilities worldwide are transforming care to empower parents and protect these precious lives, building on the framework of the Baby-Friendly Hospital Initiative.
that's right. Our mission for this deep dive is really to unpack the specific evidence-based steps that facilities are taking to ensure these fragile infants get the best possible start. And we're putting a particular focus on the vital role of human milk and breastfeeding support. We've pulled together a comprehensive stack of sources from WHO and UNICEF that lay out precisely how this transformation is happening.
Okay, let's unpack this. We're talking about the 10 steps to successful breastfeeding, but with a crucial life-altering adaptation specifically for these small, sick, and preterm newborns.
Hmm.
It's a journey, really, of profound care.
Absolutely. These 10 steps aren't just, a checklist. They're a complete framework for quality care.
Hmm.
And the challenges for these SSP infants are immense. Their tiny bodies are delicate. They're often surrounded by the intimidating sounds and lights of a neonatal intensive care unit, or NICU.
Yeah, that environment.
Right. And this entire experience can really shake a mother's confidence and sense of competency. But here's where it gets really interesting. Human milk isn't just food for these babies. It is quite literally medicine.
Medicine.
Yeah. And this calls for a profound transformational shift in how we approach care, empowering mothers to become the primary caregivers for their infants, even within these highly specialized medical settings. It's about ensuring every drop of that liquid gold is cherished and utilized.
So if we're talking about building a new foundation, that starts with step one, critical management procedures. This sets the groundwork for truly ethical and effective care, beginning with compliance with marketing codes. Now, for the average person, it might seem, well, a bit odd to start with marketing. What's the real insight here?
What's fascinating here is how deeply rooted this first step is in creating the right environment. Step 1A specifically focuses on compliance with the International Code of Marketing of Breast Milk Substitutes. The insight isn't just about following rules, it's recognizing how profoundly marketing influences both healthcare staff and new mothers, especially those under stress.
Mm.
Neonatal wards, with their high demand for specialized equipment, can often feel pressured to accept, free supplies or equipment from formula companies.
Hmm.
But by meticulously purging all commercial influence, no branded pens, pads, mugs, or calendars visible to families, feeding supplies stored out of sight, no gifts or sponsorship. Hospitals aren't just following a code, they're actively creating a sanctuary. A place where the only marketing mothers encounter is the inherent value of their own milk and the unwavering support they receive.
So it really protects those vulnerable families from, well, undue commercial influence during a critical and often terrifying time.
Exactly.
That really lays the groundwork. But in a busy NICU, how do you actually enforce something like that, especially when staff might be used to old practices or facing, external pressures?
It definitely requires strong leadership and continuous education. Staff must be educated on why this is unethical, understanding the long-term impact of commercial influence on infant feeding choices. They need to feel empowered to challenge any violations, creating a culture where adherence to the code is a shared responsibility.
Makes sense.
And that leads directly into step 1B, having a clear, written infant feeding policy. What's written down as policy really sets the tone for everything that happens on the floor.
Right.
It's essential for consistent, evidence-based care, and it needs to be multidisciplinary, involving everyone from doctors to nurses and support staff.
A multidisciplinary approach makes sense. What specifically needs to be in a policy like that for these vulnerable babies?
For SSP infants, this policy needs to be incredibly specific and practical. It should include immediate instructions on hygienic hand expression and breast pumping, safe collection and handling of milk, and the crucial use of oropharyngeal colostrum.
Oropharyngeal colostrum.
Yeah, that's where tiny amounts of colostrum are swabbed in the baby's mouth for its immense immune benefits, even before they can feed orally.
Wow. Okay.
The policy also needs to guide the transition from tube feedings to cue-based oral feeding. And critically, it must include provisions for mothers to have ample space to sleep or rest near their infant's care space, ensure unrestricted parental access, and dedicate breastfeeding rooms with refrigeration.
So real practical support for the mother's presence.
Exactly. And for families to truly advocate for themselves, publicly displayed summaries of this policy in common languages are absolutely crucial. This kind of detail demonstrates the facility's unwavering commitment to consistent, high-quality, evidence-based care for the most fragile.
I can see how that creates a clear roadmap for everyone involved. But how do you know if you're actually on the right path? That's where Step 1C, monitoring and data management, comes in.
Right, this is all about accountability and continuous quality improvement. For SSP infants, this means tracking truly detailed data points that impact outcomes. We're talking about breastfeeding initiation rates, the type and volume of feeds, how much is mother's own milk, donor milk, or formula.
So not just if they breastfeed, but how much human milk.
Precisely. We track time to first feed, discharge feeding method, the percentage of human milk intake over the entire hospital stay, and the methods of feeding at the breast, tube, cup. We also look at parenteral nutrition use and significantly rates of specific clinical diagnoses like necrotizing enterocolitis or NEC and sepsis.
This sounds serious.
They're devastating complications for tiny, fragile babies, and the fact that human milk acts as a shield against them highlights its incredible power. We also track maternal milestones, like time to first-hand expression and their expression logs.
So tracking the mother's journey too.
Absolutely. All this data needs regular review, at least every 6 months, so facilities can assess performance and adjust their practices. It ensures they're always optimizing care.
Okay, so moving from policies and data to the human element, Step 2 focuses on staff competency. Beyond the rules, why is staff training so paramount, especially for these incredibly sensitive situations?
Timely and appropriate care for mothers and their SSP infants absolutely hinges on competent staff.
Sure.
You can have the best policies in the world, but if the staff aren't confident and skilled, well, it falls apart. In many facilities without BFHI accreditation, staff knowledge might not even align with current best practices. So, Step 2 ensures all staff have sufficient knowledge, competence, and skills to support breastfeeding.
And this means everyone.
Everyone. Comprehensive, up-to-date training for all clinical staff and the neonatal ward new hires, rotating personnel, everyone. And this training isn't just lectures. It must include in-person practical components. There's immense value in specialized lactation training from professionals like IBCLCs, international board-certified lactation consultants, as well as nutritionists, OTs, PTs, peer counselors.
A whole team approach.
Exactly. The ultimate goal is to create a culture where human milk and breastfeeding are the absolute norm, ensuring every caregiver is confident, compassionate, and equipped to support these vulnerable families. It's about ensuring every hand touching that baby, every voice speaking to that mother, is knowledgeable and empathetic.
It makes complete sense. And what about preparing families even before birth? That brings us to Step 3, antenatal information. How does early preparation make a difference when you're expecting a potentially vulnerable infant?
This is where proactive support truly begins, and it's transformative. Step 3 focuses on discussing the importance and management of breastfeeding with pregnant women and their families. Evidence-informed breastfeeding counseling is a crucial public health intervention, but for high-risk women, those likely to have SSP infants, antenatal counseling must be tailored.
Tailored how?
It's crucial to discuss the special benefits of colostrum in human milk, framing it not just as food, but as medicine specifically for preterm or ill infants. Mothers need to be reassured that milk production is absolutely possible, even after an extremely preterm birth.
That must be a huge relief to hear.
It is. Teaching hand expression and frequent pumping early can make a huge difference in establishing supply. Families should also be prepared that feeding cues might be delayed in very preterm infants, which is a common concern.
Managing expectations.
Exactly. If donor human milk is a possibility, it's vital to emphasize it's a bridge to their own milk, not a replacement. And repeated discussions, prenatal through postpartum, are proven to be far more effective than just one conversation.
So continuous support.
Right. This proactive support builds confidence even before birth, managing expectations for unique circumstances and empowering them from day one.
The golden hour after birth is such a powerful concept for all babies. How is that precious time adapted for SSP infants in Step 4, considering their immediate medical needs?
Step 4 is about facilitating immediate and uninterrupted skin-to-skin contact and supporting mothers to initiate breastfeeding as soon as possible after birth. This practice is incredibly powerful. It reduces infant stress, stabilizes vital signs, facilitates breastfeeding initiation.
But how immediate can it be if the baby needs medical attention?
That's the key adaptation. For SSP infants, skin-to-skin contact should happen as soon as conditions allow. Stable is the crucial word here. It's defined as the absence of severe apnea, desaturation, bradycardia, or significant blood pressure fluctuations.
Okay.
This might happen right in the delivery room, or it might be a bit later in the NICU once they're stabilized.
And if the mother isn't stable?
The amazing thing is, even if the mother is unstable, maybe due to general anesthesia, a partner or another family member can provide that initial skin-to-skin contact.
Oh, that's wonderful.
Yeah, and crucially, routine procedures like vitamin K and hepatitis B vaccinations can often be given during skin-to-skin, with weighing happening after an hour. Safety protocols, of course, require continuous observation by a health professional if the mother isn't fully awake.
It really highlights the profound benefits of physical connection, even in the most complex medical situations.
It does. It reminds us that even medical necessity doesn't override that fundamental human bond.
Once that initial contact is made, what about the ongoing practical support for unique needs? That's step 5. How does this guidance differ for fragile infants?
Step 5 focuses on supporting mothers to initiate and maintain breastfeeding and manage common difficulties. And for tiny preterm or ill infants, skilled support is absolutely crucial. Their feeding journey can be much longer and more complex. For example, positioning for a very small baby is often quite different.
How so?
It requires additional head and neck support and easy visibility of the latch and the infant's face. You need to see what's going on. Mothers need to be encouraged to breastfeed or express milk frequently, at least 7 and 8 times in 24 hours, including at night, to establish and maintain supply and ensure thorough emptying.
That sounds demanding.
It is. And we know psychological inhibitors like fear, pain, or embarrassment can compromise milk yield. So expressing at the infant's bedside or with positive stimuli like pictures or scent clocks can significantly increase output.
Little things can make a big difference.
They really can. Teaching hygienic hand expression and promoting frequent pumping, especially in those first 3 postpartum days, can make a significant difference in establishing a robust milk supply. This step is all about overcoming common hurdles with individualized, expert guidance, because one size definitely does not fit all here.
If we connect this to the bigger picture, the discussion of supplementation for SSP infants must be incredibly nuanced. When is it truly necessary, and what does step 6 tell us about that?
Step 6 has a very clear guiding principle. Do not give breast milk substitutes or other foods or fluids to breastfeeding newborns unless medically indicated.
Medically indicated, that's key.
Absolutely paramount for SSP infants. Human milk really is medicine. It dramatically reduces risks like necrotizing enterocolitis, that's severe intestinal disease, and sepsis, a life-threatening infection. It also significantly improves neurodevelopmental outcomes. Artificial milks, simply put, lack those essential antimicrobial factors and can alter the infant's microbiome, making them more vulnerable.
Okay, so avoid substitutes unless absolutely necessary.
Right. SSP infants may require tube feeding or supplementation to consume enough nutrients, but only when medically indicated.
And what counts as medically indicated?
Well, if breastfeeding is genuinely contraindicated, which is rare, or if there's insufficient maternal milk supply despite dedicated support, or clear signs of inadequate milk intake.
Like what signs?
Things like dehydration, excessive weight loss, say more than 8–10% for late preterm or term babies, or persistent meconium stools by day 5, persistent jaundice, growth faltering.
Okay, and if supplementation is needed?
Donor human milk is the absolute first choice if the mother's own milk is unavailable. In high-resource settings, multi-nutrient fortifiers might be added to human milk to aid growth. If powdered infant formula has to be used, it must be prepared with water over 70 degrees C to kill bacteria. And mothers need clear, written instructions on safe preparation and storage before discharge.
That's critical safety information.
Vitally important. And the global standards are ambitious. At least 80% of all infants should receive only breast milk. 80% of preterm vulnerable babies should get donor human milk if mother's own isn't available. And 80% of mothers should be helped to start plentiful milk secretion within 1–2 hours after birth.
Wow, high bars.
They are. It's about a highly evidence-based approach to feeding, prioritizing human milk above all else because the stakes are so high for these babies.
The spirit of rooming in is fundamental to the baby-friendly hospital initiative. But how does that translate into the often complex, high-tech environment of an NICU? That's step 7.
That's a fantastic question. Step 7 aims to enable mothers and their infants to remain together and to practice rooming in 24 hours a day. And this isn't just about physical presence, it's about fostering that primal connection. When a mother is constantly near her baby, she learns to read every tiny signal, a sigh, a twitch, a subtle movement.
Becoming an expert on her own baby.
Exactly. In a way no medical professional can replicate. It empowers her during a time when she might otherwise feel helpless. For SSP infants, rooming in means continuous bedside care or kangaroo mother care, where mothers should be able to touch, talk to, and hold their infants.
So adapting the concept.
Precisely. This absolutely requires unrestricted 24-hour parental access. Facilities should provide comfortable spaces for mothers to rest or even sleep near their infant's care space, and dedicated breastfeeding pumping rooms with refrigeration. This constant proximity helps mothers recognize cues and significantly increases their involvement in their infant's care, creating a nurturing, family-centered environment despite the medical challenges.
It's about bringing the family unit into the core of medical care.
You got it.
That makes so much sense, really humanizing the experience. Now, deciphering a baby's signals is key for any parent, but how do we support mothers to recognize and respond to those cues, especially for the most fragile babies who might not be communicating in obvious ways?
That's step 8. Step 8 focuses on supporting mothers to recognize and respond to their infant's cues for feeding. For most babies, you wait for them to show signs of hunger, right?
Rooting, sucking.
Exactly. But very preterm infants might not exhibit immediate, clear feeding cues due to their immaturity. So initial feeds may need to be timed, for example, every 1 to 4 hours via tube, rather than solely cue-based.
Ah, okay, so cues aren't the only factor initially.
Not always for the very immature ones. However, human milk feeding, even small trophic feeds for immune benefit, should begin as soon as the infant is stable enough, often within the first few hours of life. It's also crucial that medications and treatments are scheduled to minimize interference with feeding times.
Good point.
And strategies for managing overwhelming milk flow, like non-nutritive breastfeeding at the breast for comfort or partial expression before feeding, are also important. And crucially, oral feeding readiness is based on infant stability and signs of suck, not just weight or gestational age.
So it's individualized.
Very much so. It's about learning to communicate with and respond to the unique, often subtle, needs of the most fragile babies, respecting their individual development.
This raises an important question. What about alternative feeding methods when direct breastfeeding isn't immediately possible? And what should parents be cautious about? That brings us to step 9.
Right. Step 9 counsels mothers on the use and risks of feeding bottles, teats, and pacifiers. And for preterm infants, bottles and teats are generally not recommended.
Not recommended? Why not?
They can interfere with learning the nuanced suckling patterns needed for effective breastfeeding. It's a different kind of sucking. Plus, they carry increased risks of infection, ear infections, and even dental problems down the line.
Okay, so what's the guidance?
The guidance is clear. Breastfeeding should always be initiated before any alternative oral feeding method. Non-nutritive suckling at the breast, meaning the baby is at the breast, for comfort and practice, not necessarily feeding, is strongly encouraged.
For comfort and practice.
Exactly. For comfort and pain control, even before oral competency is achieved. If oral feeding isn't yet possible, various alternative feeding methods are suitable.
Like what?
Cup feeding, or using a pallidi, is easy to teach, use, and clean, and avoids nipple confusion. Spoon, dropper, or syringe feeding is inexpensive and great for small amounts of colostrum. Feeding tubes, nasogastric or orogastric, are used for neurologically compromised or very preterm infants who can't suckle or swallow yet, allowing milk delivery while oral skills develop. And a supplemental nursing system encourages latch and normal suckling.
Lots of options besides bottles.
Absolutely. And families are also taught safe preparation and cleaning for all equipment. That's vital. This step helps families navigate complex feeding choices with informed decisions that prioritize breastfeeding where possible, understanding the subtle yet significant impacts of different methods.
Finally, we arrive at step 10, the transition home and the continuum of care. How do facilities ensure seamless support once the baby is discharged from what has often been a long, challenging hospital stay?
Step 10 coordinates discharge so that parents and their infants have timely access to ongoing support and care. This timely support post-discharge is absolutely crucial for transitioning to and maintaining exclusive breastfeeding, especially for SSP infants. That first month after discharge is particularly vulnerable.
I can imagine.
Facilities must reassess a mother's breastfeeding goals and counsel her on continuing exclusive human milk feeding, potentially with fortifiers, for up to 6 months corrected age. A detailed discharge feeding plan is essential. It needs to cover specific instructions for any supplements, fortifiers, special feeding techniques, and safe home storage of expressed milk.
So, a really clear plan.
Yes, but it goes beyond just instructions. It's vital to connect families to robust community resources,
Oh.
peer counselors, mother-to-mother support groups, and follow-up health worker visits.
How soon should follow-up happen?
Sometimes as soon as 2-4 days, and again in the second week after birth, to ensure sustained support. It's about building a bridge from the hospital to the home and ensuring sustained success for the long term, well beyond the hospital stay.
We've journeyed through the adapted 10 steps of the Baby-Friendly Hospital Initiative, specifically tailored for our most vulnerable newborns, the small, sick, and preterm infants. It's clear that these steps form a truly comprehensive roadmap for optimal care. Now, let's apply what we've discussed to a few real-world scenarios, the kinds of situations you might encounter where understanding these principles is paramount. Think about how the 10 steps apply specifically to small, sick, and preterm newborns, and how a truly baby-friendly facility would approach them, almost like practice questions.
Sounds good. Let's explore these scenarios and connect them back to the steps we've covered. It helps make it concrete.
Okay, first one. Imagine a new neonatal ward manager discovers a box of pens with a formula company logo in the staff break room. The pens were donated by a formula representative who occasionally visits. How would a facility upholding BFHI Step 1A handle this, and why?
Right. Classic scenario tied to Step 1A code compliance. The most appropriate action is C. Store the pens out of sight and prohibit their use by staff within the facility.
Store them out of sight, prohibit use.
Exactly. The code prohibits any marketing materials with logos in view of mothers or families. Even in the break room, staff using them could inadvertently bring them into patient areas or normalize the branding. Staff should challenge these violations. It's about removing all commercial influence.
Got it. Next, a new policy for a neonatal ward is being drafted to align with BFHI Step 1B for SSP newborns. Which element is essential to include? A. List of approved formulas. B. Guidelines for occasional formula. C. Provisions for mothers to sleep risk near infants. D. Schedule for nurse bottle feeding.
This relates to Step 1B facility policies. The essential element here is C. Provisions for mothers to sleep or rest near their infant's care space.
C again. Why that one specifically?
Because for SSP infants, enabling maternal presence is core to the adapted BFHI. It supports Step 7's rooming in or bedside care concept, vital for bonding, meal supply, and parent empowerment in the NICU context. The other options actually contradict BFHI principles.
Makes perfect sense. Policy drives practice. Okay, Step 1C, internal monitoring. To monitor care for SSP newborns, what's a key specific data point to track for quality improvement? A. Formula bottles for term infants. B. Percentage of human milk consumed by SSP infants over stay. C. Number of staff meetings. D. Maternal satisfaction with room cleanliness.
This targets Step 1C. The key data point is B. Percentage of human milk, mother's own or donor, consumed by infants over their hospital stay.
Percentage of human milk.
Yes. This directly measures a critical outcome for SSP infants maximizing intake of human milk, which we know is protective. It reflects how well the facility supports milk supply and donor milk use, going beyond just initiation rates. The others are less specific or relevant to this population's core feeding goals.
Right, data that truly reflects outcomes. Now let's consider Step 2, staff competency. A healthcare worker expresses concern about supporting breastfeeding for very low birth weight infants. What's the most appropriate strategy? A. Assign only experienced staff. B. Comprehensive training for all staff. C. Limit support to lactation consultants. D. Refer all mothers out.
This is Step 2. The best strategy is B. Provide comprehensive training for all staff, including in-person, practical components on supporting SSP infant feeding.
Training for everyone.
Exactly. BFHI emphasizes that all staff interacting with mothers and babies need core competencies. Limiting care or referring everyone out undermines the goal of integrated, consistent support within the facility. Specialized training builds capacity across the entire team.
Building capacity across the board. Good. Shifting gears to Step 3, antenatal information. A pregnant woman at 28 weeks is admitted with preterm labor. During antenatal counseling, what's a crucial piece of information regarding her baby's feeding? A. Prepare formula. B. Milk production won't happen. C. How to initiate hand expression pumping. D. All preterm need donor milk indefinitely.
This is Step 3. The crucial information is C. How to initiate hand expression and frequent pumping to establish milk supply.
Why C?
Because anticipating a preterm birth means preparing the mother for how she can provide her milk. Teaching these skills early empowers her, helps initiate colostrum collection, and build supply, even if direct breastfeeding isn't immediate. Options A, B, and D are incorrect and potentially discouraging.
Empowering indeed. Now for step 4, immediate postnatal care. A preterm infant born at 33 weeks is stable but on nasal cannula oxygen. Mother is stable. What's the most appropriate action regarding skin to skin? A. Delay until off oxygen. B. Place skin to skin ASAP, monitoring closely. C. Only allow if partner present. D. Do all procedures first.
Step 4, application. The answer is B. Place the infant skin to skin with the mother as soon as conditions allow, monitoring closely.
Even with the oxygen.
Yes. Stable doesn't mean completely free of support. If the infant's vitals are stable on nasal cannula, the benefits of skin to skin are immense and should begin promptly with appropriate monitoring. Delaying unnecessarily misses a critical window.
Powerful adaptation. Moving to step 5, support with breastfeeding. A mother of a 30-week preterm infant struggles to maintain milk supply. Baby is tube-fed. Which intervention is most likely to help increase volume? A. Limit pumping to 3x day. B. Encourage frequent expression, 7th of aches a day, ensuring emptying. C. Only pump when baby at breast. D. Recommend formula due to presumed insufficiency.
This is step 5 in action. The most effective intervention is B, encouraging her to express milk frequently, at least 7 to 8 times in 24 hours, including at night, ensuring thorough emptying.
Frequency and emptying.
Absolutely. Milk supply is driven by demand, or in this case, removal. Frequent and effective expression mimics what a baby would do and is key for establishing and maintaining supply, especially when direct breastfeeding isn't happening yet.
Consistency is key. Next, step 6, supplementation. A small for gestational age infant, 4 days old, exclusively breastfed, has infrequent wet diapers, persistent meconium, and 9% weight loss. What's the most appropriate initial response? A. Immediately recommend formula. B. Assess for inadequate intake, provide targeted feeding assistance. C. Reassure mother it's normal. D. Advise less frequent feeding.
Step 6, critical thinking. The initial response should be B. Assess for signs of inadequate milk intake and provide targeted breastfeeding assistance.
Assess and assist first.
Yes, these are clear signs of potential problems, so reassurance, C, is wrong. Before jumping to Formula A, a thorough assessment of the breastfeeding diet is needed to identify and correct issues. Supplementation is only considered if assistance fails or there are urgent clinical signs, and even then, donor milk might be preferred.
Clarifies the sequence. Now for step 7, rooming in. Mother of a very preterm infant is in an NICU where single rooms aren't possible. How can rooming in be effectively implemented? A. Limit visits. B. Encourage 24-hour access, provide space near bedside. C. Rely on nurses for all care. D. Move infant to nursery when mother rests.
Applying step 7, the answer is B. Encouraging unrestricted 24-hour parental access and providing space for mothers to stay near their infant's bedside.
Adapting the principle.
Exactly. It's bedside care. Even without a private room, maximizing parental presence and involvement is the goal. Limiting access or separating the diet goes against the core principle.
A truly family-centered approach.
Yeah.
Finally, step 9, feeding bottles, teats, and pacifiers. Mother of a 32-weeker transitioning from tube feeds asks about introducing a bottle to help baby learn to suck. What's the most appropriate counseling? A. Bottles are efficient. B. Encourage non-nutritive suckling at breast. Offer cup feeding first. C. Suggest slow-flow bottle teat. D. Bottle feeding is necessary for weight gain.
Last one. Step 9. The most appropriate counseling is B. Encourage non-nutritive suckling at the breast and offer alternative feeding methods like cup feeding before introducing a bottle.
Breast first, then alternatives like cups.
Right. For preterm infants, bottles can interfere with learning to breastfeed effectively. Promoting practice at the breast, even non-nutritive, and using methods like cup feeding supports the transition to direct breastfeeding, which is the primary goal. Bottles are generally not the preferred method in this context.
We've journeyed through the adapted 10 steps of the Baby-Friendly Hospital Initiative, specifically tailored for our most vulnerable newborns, the small, sick, and preterm infants. It's clear that these steps form a truly comprehensive roadmap for optimal care.
And if we connect this to the bigger picture, the profound impact of human milk and these BFHI principles on the survival and thriving of these vulnerable infants cannot be overstated. This isn't just about feeding. It's about fostering survival, optimal growth, and neurological development through complete integrated system of care, from foundational policy decisions right down to compassionate, highly skilled bedside support.
Yeah.
It truly recognizes the inherent power of human milk as medicine and the irreplaceable role of parents in their infants' care, even in the most challenging medical circumstances.
So, what does this all mean for you listening? Perhaps it's a powerful reminder of the incredible resilience of both mothers and infants, or the profound impact that systemic, evidence-based care can have in the most delicate situations. It might encourage you to learn more about the initiatives in your own community, or simply to appreciate the quiet, transformative work happening in neonatal wards every day. What else might you discover by looking deeper into this topic and asking how these principles of integrated, family-centered, evidence-based care might be applied in other areas of healthcare beyond the NICU?